Hello, everybody, and welcome to our TIF Talk Tuesday. Thank you for joining us. I'm Andrea Millers with Endogastric Solutions. I'm very excited about our special guest tonight. Before I introduce her, I want to just remind everyone this is a live event, so at any time, if you have any questions and you'd like to ask Dr. Koon or our special guest, I haven't introduced her yet, but if you'd like to ask her any questions, please feel free to type it into the comment section and we will do our best to answer the questions. So tonight, I'm very excited. We have Dr. Amber Koon. Welcome, Dr. Koon, and thank you for being here with us tonight.
Thank you so much for having me.
You're welcome. Let me give you a little background on Dr. Koon. She received her medical degree from the College of Osteopathic Medicine at Rocky Vista University, where she also completed fellowship training in predoctoral osteopathic principles and practice. She went on to complete her general surgery residency at Henry Ford Allegiance Health. Dr. Koon's surgical practice is located in Henderson, Kentucky, and her special interests include robotic surgery and minimally invasive GERD interventions, including the TIF procedure for reflux. So again, Dr. Koon, thank you so much for being here tonight with us.
Thank you.
So the first thing I see there's a couple of questions that have already popped up. But before we go into the questions, we're going to kind of start off and explain maybe what is GERD, what could patients potentially feel if they were suffering from GERD or acid reflux?
Yeah, so GERD or reflux is just the movement of the stomach contents of acid that's down in your stomach up into your esophagus. So it just the valve that's there or the muscles that are there have loosened up over time, and so it's not functioning the way that it was before, and so those contents can come up into the esophagus. Some of the symptoms that you experience with that is that typical heartburn feeling that you have, that lower chest pain, sometimes even going up into your chest, or the regurgitation, the feeling of food or fluid in the back of your throat, and then that indigestion kind of feeling that people get.
Right, thank you. And when I'm assuming as a general surgeon, do you see patients kind of at the front end, or are they already at that end where they're like, this is terrible, I need to do something? And the reason why I'm asking that, the question I have for you is, what do you normally recommend patients to do, kind of that initial, if they're initially starting to feel GERD or having that occurrence more than usual, if you will?
Yeah. So I'm in a really unique situation here in Henderson that I do some scopes, and so I get those initial referrals sometimes from the family doctors before the full workup. But then I also get the referrals from the gastroenterologist. So they've already had the EGD, they've already gone through those conservative measures to treat GERD and treat reflux. So I'm kind of on both sides. If I have someone who's coming to me for the first time who hasn't had that full workup, we talk about lifestyle modifications and medication. But doing what I do, we often progress quickly to, do we need to do some other kind of intervention? Because most of the time people have been on these medications for years by the time they make it to me. Now, if you've already seen the gastroenterologist and you've been on the medications, you've changed your lifestyle, most of the time you get sent to me because you've got a hiatal hernia. And then we're talking about fixing that or doing the TIF, just depending on what your anatomy looks like.
Perfect, thank you. Before we go into kind of the diagnostic workup to determine, what's the next step for patients, can you tell us a little bit about maybe what would happen if a patient did not get their GERD treated?
Mm-hmm. So we talked about that reflux of the acid or the stomach contents up into the esophagus. So your stomach, the lining of your stomach is made to handle that acid, but your esophagus isn't. And so when the bottom of your esophagus is continually bathed in that acid, the cells start to change. Your body starts to try to take care of itself and change that so that it protects the lining of your esophagus from further damage. But unfortunately, once those cells start to change and do a different job, they forget what they really should do. And so they're changing and evolving, and that's when things can turn into cancer. So that initial change is considered Barrett's esophagus. So that's when we'd like to catch things so we can reverse things or treat it before it progresses into esophageal cancer.
Thank you for explaining that. Can you talk a little bit about the kind of progression of treatment options? Maybe go into a little bit more about, so we talked a little bit about lifestyle treatments, lifestyle changes and particularly diet changes, and then like that next level of taking medications and then so forth.
Mm-hmm. So those initial recommendations is avoid your trigger foods that you know about. Most people know those foods that cause it for themselves. Other things to consider doing is not eating or drinking within 2 hours of laying down. So whether or not that's bedtime or if that's during the day, depending on your schedule. But some of the other two other major things that I really recommend for my patients is to stop smoking, because that increases your reflux. And then weight loss, unfortunately. All of us have a problem with it. But when we have that increased pressure in our abdominal cavity from the increased weight, the easiest release valve is up into your esophagus. So that pressure's on your stomach and it goes up. So those are those lifestyle modifications. And then we get into the medications. So you have those immediate treatments like Tums. Everyone knows Tums. And then you can transition into something that's more preventative or a longer term treatment. So like an H2 blocker, which is like Pepcid, or a PPI or a proton pump inhibitor. So that's your Prilosec, your Nexium, those kind of things. They can be over the counter where someone just treats themselves, or you can get it from your doctor. The hesitation I have for someone just getting something over the counter is that what if something else is going on? Something that I can treat for you and I can take care of, or more importantly, you're treating symptoms of something that indicate that we need to be doing something else.
Yeah, that's a really good point. Thank you for mentioning that. I think we hear a lot of people on here saying, "Oh, I just take, I just kind of self-prescribe myself some PPI or Meprazole or whatnot." And to your point, it may not be even GERD that they have, right? Or reflux.
Right. Or it's the changes into Barrett's that we really need to watch, and we need to make sure they don't progress.
Let's talk about that. So the next step of after, taking PPIs and people that suffer from GERD, they're probably taking it for a very long time and get to a point where, okay, I've got to do something. My life is miserable. What diagnostic testing do you provide to determine, are they a candidate for the next step, if you will?
Right. So I always initially start with an EGD or a scope from above. So it's a long camera with it on a tube. So I can go down and I look at your esophagus, I look at your stomach, look at your first part of your small intestine, make sure there's not something else that's causing the symptoms, because it's not all just reflux. But then also we can take biopsies and really look at those cell changes, make sure nothing else is happening. From there, I can also see if we've got a hiatal hernia, which is kind of why I'm here. So those two things really make a difference for my treatment there. If after your EGD, I don't really see the evidence of the reflux like I would expect, I don't see a hiatal hernia, that's when we start to go and do some of the other workups that we've got. So we look and do a special test that actually measures the acid that goes up into your esophagus. And then we can also look and see how well does your esophagus actually work. Does it contract the way it should? Does it not contract? Does it not relax? Those are things that then I get you over to my gastroenterology colleagues if we need to do a little more specialized testing, because you may have some other things there that don't need surgery. And that's what their fellowship is for, is to treat those conditions. So I get you there.
Right. That's perfect. Thank you. And I do see quite a few questions popping up. So I'm going to pass it over to Wendy to get some of these questions asked. So.
Well, thank you very much, Andrea. Dr. Koon, you've got lots of fans, apparently. So thanks for being here with us tonight. I'm going to go ahead and start with Caesar. We do have a good number of questions on medications. So let's touch on the highlights. Some of them kind of are same subject. So if I don't ask your question specifically, I'm thinking that you'll probably get your answer based on another person's question. So Caesar is asking, does taking Pepsid AC 10 milligrams nightly have negative long-term consequences?
So ultimately, the H2 blockers don't have as many side effects or long-term effects as the proton pump inhibitors do. They're just not as effective. They hit a different acid receptor, essentially. Some of the concerns about taking the PPIs long-term is that it can decrease your bone mineral density, which can lead to fractures or breaks. And then it decreases your ability to absorb certain nutrients or vitamins. And then the other one that is getting a lot of attention is the link to dementia. And no one wants to be on a medication for long term that can cause something like that because you're just waiting for that day.
Gotcha. Thank you. So we have Edie who's asking, does taking digestive enzymes and other supplements help heal the gut?
So it depends on your condition and what you're taking it for. That's a very broad, digestive enzymes is kind of broad. So if you've got pancreatic insufficiency, yes, you need to be taking your enzymes that are prescribed by your physician. If you're talking about more of a holistic approach or supplementation, the hard part about that is a lot of them aren't regulated. And so you don't really know what you're getting in the supplements. And I think that as long as what you're taking is safe and doesn't interact with any of the medications that you are also on, and they don't cause any side effects that can be detrimental to you, I think that's fine. But individually, it's really hard for me to tell you without knowing what exactly are you on, why are you on it, what symptoms are you having, who prescribed it to you, who suggested it to you, where did you get it. That's a big basket to unload.
Yeah, well, yeah, to your point, that just goes back to even, the folks that have those heartburn symptoms, and say, okay, well, I'm going to run down to the pharmacy and grab something. At what point do you say to them, hey, it's time probably for you to come on in and see somebody to make sure that we are indeed checking out what you're treating yourself for and making sure that that's the appropriate therapy?
Yeah, so I think a lot of that is how long have your symptoms been going on? Like, for example, I had a really bad reflux when I was pregnant. Makes sense, right? I've got increased pressure inside my belly, everything is pushing up, but I knew there was an endpoint there. And I knew that taking medication while I was pregnant was, at least for symptomatic relief, was okay as long as after I delivered, those symptoms resolved. If something continues after that, you really have to look at, is there something that I'm doing that's causing it? So those lifestyle modifications, or do we need to look into this further? So the FDA only approves PPIs for 14 days, for 2 weeks. So if you're needing that for more than 2 weeks and you come off of it and your symptoms return, maybe we need to look at it a little farther.
Very good. Thank you. I am also seeing a question from Haley asking, since you did mention hiatal hernia, is there a correlation between hiatal hernia and GERD?
There is. So a little bit of anatomy for everyone. People who know me know I like anatomy. So you have your diaphragm, that's your breathing muscle that goes across your belly. And you have a hole that's there naturally. That's where your esophagus comes down and your stomach. So I'm going to use my hands because that's how I am. So you have a hole that's there normally. It should be small. Your stomach should sit underneath it. Your stomach shouldn't come up through that hole. But a hiatal hernia is when that hole starts to open some and then your stomach starts to come up through that. So that natural valve, that tissue that's there that prevents that reflux is where that hole is at. And if that gets up above there, you don't have that diaphragm to help with the physiology of keeping the contents down. So then it's easier for whatever is in that little pouch above your diaphragm to come up and down into your esophagus. So that can lead to symptoms like what we call dysphagia or difficulty swallowing. And it can also lead to increased reflux because that tissue is that continual bath of acid there. And it can lead to some stricturing of your esophagus at that point too.
Excellent. Okay, thank you. Last but not least, I'm going to ask, can you talk a little bit about silent GERD, and is it worse than regular GERD?
So I think the reason it's worse is that people don't know what's happening. They don't have that typical symptom that, I've got the heartburn, I need to take something for it. Some of those atypical symptoms are really what trigger us to think that you've got some reflux. So a chronic cough actually can be GERD because that acid is coming up into the back of your throat. It can increase the phlegm that's in the back of your throat because your body's trying to protect itself. So that throat clearing that you've got all the time, even as much as asthma-like symptoms can be from reflux because it's coming up into the back of your throat and then your body is not able to fully protect itself, and that acid can get down into your airways and create a reactive airway. So is it worse? It can be, but I think the problem is that it's unrecognized.
Excellent. Thank you so much. All right, Andrea, I'll turn it back over to you, and we'll get to our next group of questions shortly. Thanks, everybody, for tuning in.
Thank you. So let's talk about the TIF procedure and how does it work. So maybe you can explain, and then you can even talk about how it's correlated with the hiatal hernia repair as well, if you don't mind.
Yeah. So if you have less than a 2 centimeter hiatal hernia, so you can have a really small hiatal hernia and you don't need to have that repaired specifically, we can just go in and do the TIF. So essentially the TIF device is on the EGD or the scope and comes down through your esophagus, pulls everything down underneath that diaphragm like we were talking about, and then bulks that tissue up. It folds your stomach up around the bottom part of your esophagus, and we use fasteners to hold it in place. They're permanent fasteners, but they look a lot like the T fasteners from when you get a package of socks. Looks a lot like that. So you see the two sides on either side, on the outside of the esophagus, like on the where the stomach's up, and then you can see them from the inside too. And that essentially is what a TIF is. It just restores that anatomy and that function that you had before anything got too loose.
Yeah, perfect. And then maybe talk about the hiatal hernia repair. Does that happen before? Does it happen after? I mean, I know the answer, but I'll let you explain.
Yeah. So if you've got a hiatal hernia as well, something greater than 2 centimeters, like we were talking about, I do a hiatal hernia repair beforehand. I do those minimally invasive. I do them with a robot. So you have 4 little incisions that my instruments go through, and then a smaller incision that goes in and helps hold your liver up so I can get down into that space that I need to work. I pull everything out of that chest cavity, anything that's gone up that shouldn't be there. So for the small ones, that's just your stomach. For some of the bigger ones, we talk about other organs that end up in there, but that would be something we're not really talking about the TIF for. This would just be some of those smaller ones where the stomach has started to go up. So we pull everything back down. We close down that hole to the shape, to the size that it should have been, the size that it was originally. And then, depending on the patient, each person's a little bit different. I may do a partial wrap. I just do an anterior wrap rather than the traditional Nissen, which is that 360 wrap. I had the pleasure of training under Dr. Kulkarni, who is someone that you all know very well with endogastrics. And in seeing just the evolution of his practice while I was in residency, that was something that I really wanted to bring to my practice. And so I don't do that wrap, that 360 wrap, because it leads to so many of those side effects like bloating and just that problem swallowing because it's so tight at the end. And then you can't throw up either because all of that is held down. So sorry, I digress. So I either do an anterior wrap, or we go in and we just do a straight TIF after everything has been restored back below the diaphragm.
Perfect. Thank you. I'm glad you mentioned the Nissen procedure and kind of the differences. That's one big question we always get. What are the differences between, the different anti-reflux procedures? Is there any other ones that you want to talk about, or are you just...
So there's some other approaches. Each surgeon has their own thoughts, and specifically when you see patients, it's part of the evolution of your practice is that anytime you have something that you're not quite satisfied with the outcome of, or, you know, they develop this symptom or this reaction, how do I change that to make it better for the next patient? So each person has a little bit different idea. There's the anterior, meaning a wrap in front. There's the wrap behind. There's this entire 360 wrap. There's also some devices that I don't have any personal experience with. There's something called the Lynx. It's like a magnetic bracelet that goes at the bottom of the esophagus. I think there's probably some others out there that I just don't know because I don't do them. You look for those new innovations when you're unhappy with what you're doing, and I'm very happy with what I'm doing.
Fantastic.
So
that's great to hear. Let's talk about first off, I do want to say there's people from Jackson that are coming on saying hi, so you can give a little shout out to your Jackson people.
The Jackson people, I miss you all.
Yes. Let's talk about the day of, or kind of what can a patient expect. And I'm moving into kind of the recovery part because that's always the big one.
Yeah.
So maybe just briefly, what can they expect when they come in to have their procedure? How long are they in the hospital? And then maybe what does post-op look like? Are they there overnight? Are they there longer? Whatnot?
Yeah, and your recovery afterwards. That's the major, I think the major limitation for a lot of people when they decide to go forward with this procedure. So to lead up to it, if you are having a hiatal hernia repair, we do a 2-week low-fat diet beforehand, and that's essentially to help decrease the size of your liver so that I'm not putting as much pressure on it as I lift it up to get into that space. And then you're nothing to eat or drink for at least 12 hours before surgery, just depending on timing. And then you have your surgery or your TIF procedure, depending on what you're having done. After that, you get to stay with me overnight in hospital. I want to make sure that everything is going okay, that you're able to swallow okay, that you're able to handle your own secretions or your own spit. And then that next morning, you get to try your clear liquids. And we do that. I do those for at least 24 to 48 hours, just depending on how you're handling it and how it's feeling for you. And then we slowly increase our diet. So for the first 2 weeks, it's a full liquid diet. So things like, after those 48 hours, so things like milk, you can start to add that back in. You can do milkshakes and then start to increase into protein shakes, that kind of thing. Weeks 3 and 4, we go into something that's a little more pureed, something a little thicker. And the reason we do that is that when we initially do that surgery, we create a lot of inflammation and swelling in that space. And so there's only so much that can get past that. And as time goes on, the swelling goes down, and we want to stretch it just a little bit, but we don't want to stretch it so much that we're completely ruining everything we just did. So that's why there's a gradual progression. Once we get to weeks 5 and 6, you are doing softer foods, and then on week 7, you're back to normal food. During that whole recovery period, you also have a limit for your lifting, pulling, or pushing. Anything greater than 10 pounds is a no-go for those 6 weeks. And again, that's because we don't want to increase that pressure around what we just repaired. You and I just went through a major surgery and a major procedure, and we don't want to have all that be for nothing.
Yeah, I love that. Well, first of all, I love that you say you and I went through this procedure together. That's very endearing and would make me feel very comfortable if I was having surgery with you. So that's great. Thank you for that. So I think, what about activity and work? Can people go straight back to work, or is it, a couple days, weeks, or depending?
Yeah. It kind of depends on what you do, right? So if you have a desk job and you're sitting most of the day, if you have just a TIF, you are probably ready to go back to work in 2 to 3 days. If you have the hiatal hernia repair as well, and you have a desk job, you may be ready to go back in a week. It kind of depends on your body and how you're feeling. if you have a physical job, if you're a police officer or a construction worker, you're going to get to take the 6 weeks off with me. And you're going to get to see me a couple times during that time, because I want to make sure that you're progressing as expected before I send you back, and before we stress that whole area
Yeah,
again.
perfect. Thank you. Wendy, I'm going to pass it back to you to get some of those questions answered.
Thank you. So we do have a couple surrounding TIF and then TIF with hiatal hernia repair. First thing I'll ask
Okay.
is, can you have TIF if you have Barrett's esophagus?
Yes. So there's Barrett's esophagus with the beginning cell changes, and then as it progresses into a more concerning cell changes. If we're at the beginning of those cell changes, that's when we can do this, because we're going to decrease the exposure to the esophagus to that acid. If we start to have those cell changes, that's when we need to treat those before we go in and we do this procedure. So I send you to my gastroenterology colleagues again, and they can do some things where it actually removes those cells and allows your body to heal that space before we go in and we do any kind of procedure there.
Thank you so much. Also, you just touched on this, but I feel like it's important to go ahead and discern whether this applies to just TIF or TIF plus hiatal hernia repair. Matt's asking if he has to stay in the hospital overnight if he just has the TIF procedure. Does it matter if the hiatal hernia is repaired too?
I keep you for both, because I want to make sure that you're not having any nausea or vomiting after the repair, because I am in that space working around nerves that can get irritated. So I want to make sure I'm controlling your nausea. I want to make sure that you're not having any pain, because that's kind of my signal is something else going on. A TIF and a TIF with hiatal hernia repair, those are both surgeries. While they may look non-invasive, they may look minimally invasive, it's still major surgery. And there's still a possibility of any kind of complication. Anytime you use a device or you have surgery, there's a risk of complications. So I like to make sure that you're doing okay before I get you out.
Awesome. Thank you. Also, again, TIF versus TIF with hiatal hernia repair, just in talking a little bit more about exercise, just light exercise, is there a difference in, just the progression track on a straight, just TIF only versus hiatal hernia repair?
That weightlifting limit is the same for both, because it's, again, for your TIF, we're just holding everything in place with those little sock fasteners. So we need things to scar in place before you really stretch it, or before you test it. So either way, there's the weightlifting limitation there. I do want you active though. I want you up and I want you walking. I want you walking around the neighborhood. I don't want you going out and running just yet, but I want you to be doing something that is going to help in your recovery. The more you sit around, the more pain you're going to have for anything that you do. The more you're up and using those muscles, the faster your recovery will be.
Excellent. Lastly, just any immediate tips for success that you talk about with your patients prior to them taking the plunge here?
Yes. So I'm going to show you something that I've got because I'm super proud of this. This is a little booklet that every one of our patients gets. Inside of it, I'm going to show you, it's got shopping lists. It's got recipes. So I give you the recipe for success. So it tells you what you should buy, what you should have in your fridge before you go out and before you come to the hospital. And then also, I think having a plan in whatever you do, that's when you're set up for success, right? So if you have a plan of, I'm going to come home and I know I'm going to really want to eat something, but I can't, and this is what I'm going to have at this time, and this time, because then you have something to look forward to. Oh, I get this Italian ice that I really like, something that is going to kind of excite you for what you're doing, because it's going to stink for those 6 weeks. But I think if you plan for it, you're going to be a lot more successful. And like I said before, we're in this for the long haul, and I don't want to have to do all that work for something to happen. And I know you don't want to go through all of those, the risks and just the discomfort for something to not be successful.
Absolutely. Yeah, you couldn't have said it any better. I do have a question that just came in from Chris asking if there's a difference in recovery time and diet restrictions between the Nissen procedure that you talked about and the TIF.
So the TIF and then the C-TIF, or TIF with hiatal hernia repair, recovery-wise for a Nissen and then with a hiatal hernia repair are about the same depending on the approach. So if it's minimally invasive, so little incisions instead of a great big incision, you're going to feel pretty good in about 2 weeks or so. If you're just having the TIF, you're going to feel good in a day or so. And you may not even have any real symptoms the day afterwards. It's just that I'm a little cautious and want you to hang out with me.
All right, very good. Thanks, Andrea. I'll turn it back to you.
Fantastic. Thank you. I was going to say, you probably need to publish that book because there's going to be a lot of people wanting that tip before and after guide that you have. So yeah, for sure. Before we conclude for the night, I'm sorry, I do hear a little bit of echo, so if you hear it, I apologize. But before we do part, I want to give you an opportunity to give any advice that you would give people who are suffering from GERD. What would that advice be?
Essentially, if you're unhappy, look for your options. Look and see what we can do for you, because I know that taking a medication every day is rough. I have a really hard time remembering to do it. I'm a doctor. I know that's what I'm supposed to be doing, right? And I have a hard time wanting to change some of my lifestyle too, just so that I don't have some of those symptoms. So if you're suffering, why not look and see what we can do for you? And one of the best things is to come see your physician, come and see your family doctor, come see a surgeon. If you already have a relationship with me, by all means, ask me about it. If you can't tell, I kind of like doing this. So I will gladly talk to you about all of it. And I'll teach you all the anatomy and I'll show you how it works. But I think that having that knowledge at least lets you make informed decisions. And then you can decide, do I want to go through the 6 weeks of the diet at this time, or do I want to wait and do it later, or do I want to try some of these other modifications that maybe I just haven't done yet?
Fantastic. Thank you so much. Wendy, do we have any other questions that came through?
I have not seen anything, but that doesn't necessarily mean that it's not there. I've had a little bit of an interruption in being able to receive some questions on my computer. So if they're out there and I haven't gotten them and you can see them, feel free. Otherwise, let me apologize if anybody has sent them and we haven't seen them yet. The one thing that I will say is probably just because we haven't had a chance to be able to do it in the feed yet, is remind everybody about the GERD Help app that's available that might be able to help with some of the points that Dr. Koon, oh, look at that. Okay, it's popping up now, that Dr. Koon has mentioned too, just in helping folks print out a summary sheet for their doctor, giving them a list of questions to ask their doctor, because to your point, Dr. Koon, I think making the most out of your visit includes doing some prep. It's not just up to the doctor to prep, it's also up to us as the patients to help share as much timely information as we can. Can you talk a little bit about what are the things that you ask first that it really helps for folks to have a specific answer on as you start determining what their care pathway needs to be?
So essentially, how symptomatic are you? How often are you having these symptoms? And is it worth going to something that's a little more invasive than just medication at that point? And how reliant are you on those medications? I know that there's the checklist on the GERDhelp.com. I also have a checklist in the back of my little book here. I know. So it goes through it, and it can also help you with your progress before and after. But it's some of those like, how often are we having problems? How bad is it? How much is it impacting your lifestyle? So if it's something that you're like, it's kind of a minor annoyance, it's only happening a couple times a month, then maybe we wait. But if it's something, especially if it's every day or multiple times a day, come in with that information for me. Tell me what you've tried, what you haven't tried, what you're not willing to try, because that all leads up to what can we do for you.
Excellent. Thank you very much. All right, Andrea, I think that's all we've got. Oh, wait. Nope. Sorry. If my doctor doesn't know about TIF, how do I find somebody who offers it?
GERDhelp.com. You can put your zip code in there, and it'll show who's available. If you're in the Henderson area, I am more than happy to help you. You can call my office, and if your insurance needs a referral, we can get you in touch with your family doctor, and then they can put one in.
Excellent. Look at that. We've got all kinds of people helping that are, shoot, I may have to go look for another job because everybody So last but not least, here's one that hasn't been touched on. Will insurance cover a TIF or a CTIF?
It will. So previously for insurance to cover it, it was that you had failed medical management, but not so much, because otherwise then they'd say that surgery wouldn't help. And we've got to the point where we know there's enough side effects with some of these medications, and that this is a long-term repair. And so insurance does cover for it. We submit it for a prior authorization beforehand, so that you don't have any surprises, but it definitely does cover both individually. We just have to do the proper workup and submit the proper documentation before.
Fabulous. Thank you so much. Okay, I promise I'm done now. Andrea, back to you.
Thank you so much. And gosh, I know there's tons of people asking questions, so I can't thank you enough, Dr. Koon, for everything and for being on here with us today. As Dr. Koon mentioned, if you are looking for a surgeon or a physician, I should say, a GI or a surgeon that does the TIF procedure, you can go on GERDhelp.com. We do have a physician finder on there. And then I know you love Dr. Koon's book that she has. We actually have something somewhat similar, probably not as good as Dr. Koon's, but we do have the mobile app that is available. It's free for patients or people to use. It's GERD Help. Just go to your mobile app and download that, and there's tons of information there, including kind of pre and post-op information, also areas where you can track how you're doing, track how you're feeling, track the foods that you're eating, and also some videos as well, and some diet and exercise examples as well. So if you have some questions and want to jump on there, you're welcome to do so. Again, Dr. Koon, we can't thank you enough for joining us this evening, and for everyone watching tonight. Thank you so much. We will get you next time, next Tuesday, on our next TIF Talk. Until then, everybody have a great evening. Thank you very much.
Thanks, Dr. Koon.
Thank you.